All right, good morning, everyone.
Good morning.
Well, it's definitely livelier than in the past. Welcome to our MD Expo presentation on how to prepare for a Joint Commission survey. I'm Lindsay, Pristou, and I'm joined by my co-presenters, Arif, Subhan, and Bhaskar, Iduri. So after attending this session, we're hoping that you're going to be able to learn practical strategies to prepare for a Joint Commission survey, including how to interact with your surveyors, being able to identify and perform an audit on your medical equipment management plan and any deficiencies that you identify in your program, as well as being able to identify the hot topics that Joint Commission is focused on in 2025 specifically. So a little bit about ourselves. Our first presenter is Mr. Arif Subhan, who is the Chief Biomedical Engineer at the VA Greater Los Angeles Healthcare System. He's a certified clinical engineer and very involved in many HTM organizations, including ACCE, the University of Connecticut, Journal of Clinical Engineering, Amy's BINT Journal, 24/7 magazine, and he's also authored chapters of the Clinical Engineering Handbook. And he's a recipient of several ACCE and Amy awards. He's also my boss, so make me look good. Yeah, right.
Yeah,
Not in the government. But so our next presenter is Bhaskar Iduri, who's the IT Director of Clinical Engineering at Sharp Healthcare based out of San Diego. And he's also a certified clinical engineer at CHTM. He's been in the HTM field for 11 years and is currently the treasurer for ACCE and a technology management council member for AIM. I'm Lindsay Pristou. I'm a biomedical engineer at the VA Greater Los Angeles, and I've been in the HTM field for just shy of 4 years now. I started my career in the VA TCF, or Technical Career Field internship, which I know we have some of those members here. And I transitioned to a full staff engineer about 2 years ago. Outside of working for the VA, I'm an active phase 1 fellow in MIT's Link2 Catalyst cohort, which is a focus on new innovation for healthcare projects and startups. We also wanted to thank Captain Navarro at the program office. She helped develop our presentation and the content in our presentation. I wanted to give a thanks to her as well. So that's a little bit about ourselves. Here's a list of the topics we're going to be covering today. I know you guys chose to come to an 8 a.m. session to learn about standards, so I don't want to spoil your day by saying that it's going to be a very eventful conversation, but it's really applicable, and we're really just going to be providing an overview of the Joint Commission survey process, what to expect, going over organizational survey differences, since there are differences between deemed versus non-deemed facilities. And then we're going to go over our bulk of our presentation, which includes preparation advice, overall overview of standards, collaboration, common findings, etc. So before we begin, and because it's early, I wanted to get some interaction with the audience and get to know you guys a little bit better. So we're going to start with some polling questions. So we're going to ask you guys to raise your hands to get a sense of your experience with the Joint Commission process and the HTM field in general. So the first question is how long you've been in the HTM field. So please raise your hand if it's been less than 10 years. Okay. A lot of this is yes. Fun. Great. Okay, 10 to 20. Okay, 20 plus. Okay, I think that's a good distribution. Definitely on the greener side though. And how would you rate your knowledge of Joint Commission standards and survey process? So raise your hands if you feel that that is a low. You're like hiding it. Medium? Okay, and high. Why are you guys here? Just right? Right. Okay, and then raise your hands who amongst you is responsible for the preparation of the Joint Commission survey process directly. Directors of programs. Okay. Very cool. Who are the lucky ones that have had a Joint Commission survey in the last year? Okay, maybe you can speak to some of the new hot topic areas. Every year they seem to pick one. And before I begin, can anyone name the 2 EC standards on medical equipment? You're just full.
I'm just.
Okay. Can anyone take a guess at which EC standard related medical equipment has the highest 2024 findings in Joint Commission? PM compliance, yes. EP3, EC243, but we're going to go over all of that. All right, so let's begin. It's going to be a fun ride. All right, so we're going to begin with an overview. Next slide. All right, so the Joint Commission survey is one of the key inspections in the healthcare industry. It was founded in 1951 as an independent, non-for-profit organization. It is the nation's oldest and largest standard setting and accrediting body in healthcare. Being an accrediting body basically means that they act on behalf of the Center for Medicaid and Medicare Services, or CMS, to accredit hospitals to receive federal funding. And Joint Commission is also known as the Gold Seal of Approval, and it provides recognition that healthcare organizations are meeting a certain set of quality standards and safety standards. So for healthcare facilities to earn a Joint Commission accreditation, they do have to undergo a full site survey every 3 years, but it can range from 18 to 36 months after the last survey. So you may hear the term being in the Joint Commission window, 18 months after the last survey. This full survey is considered scheduled, but it is unannounced, so the healthcare systems don't know until they're knocking on their door that the Joint Commission is going to be there. And they also perform unannounced surveys of new clinical programs or new additions after they've been notified of additions to your healthcare systems. And they can also conduct unscheduled surveys when it becomes aware of serious standards or compliance violations or patient care, treatment, or safety issues. These are called for cause. And a for-cause survey can be initiated by a patient safety event or an anonymous complaint to the Joint Commission. Joint Commission also has different sets of standards based on the type of healthcare facility. There are specific standards for hospital, ambulatory, behavioral health, laboratory. For this presentation, we're going to be focusing specifically on the hospital accreditation standards, since that is primarily the type of accreditation that you will undergo. And so for hospitals, the answer to the prior question, the two main Joint Commission standards related to HTM, biomedical, clinical, whatever you call your guys, is the Environment of Care EOC chapter, EC 020401, the hospital manages medical equipment risks, and EC 020403, the hospital inspects, tests, and maintains its medical equipment. So under each of these ECs, there's specific EPs or elements of performance, and they go through the specifics of each standard. So we'll go over those a bit later. Alrighty, so what happens when they show up? The group's going to consist of a team leader, which is usually a physician or a nurse, and a life safety code surveyor, or LSCS, who's responsible for evaluating the specific EOC standards, and other clinical team members depending on the size of the survey team. And the length of the time for the survey is dependent on the size of your hospital. So do note that they could range from one site to another, but they're usually on site for at least 2 days. The surveyors will follow a see it, cite it methodology. So if they find something that does not meet their standards, they're going to cite it as a finding. And there are two components to the survey process: the documentation review and the facility walkthrough. So during the documentation review, this is when you're going to meet with surveyors and others from the EOC that your hospital has, and you're going to review the documentation, your hospital's policies, making sure they meet the Joint Commission standards, and that they are in fact following these policies. And this is when you may get questions about your medical equipment management plan, and you'll need to respond and possibly show proof through documentation. And if you don't know the answer or have the documentation available at that point, you can ask to get back to them with that information. They could issue an IOU to produce documentation by a certain time. Just you're going to need to make sure to meet that deadline. And during the facility walkthrough, a little different, the surveyors are going to tour and inspect different areas of the hospital and walk the floors to really visualize that not just do you have these policies written, but that you're actually following them in practice. And you should likely be attending this walkthrough as the biomed representative and be prepared to answer questions on medical equipment. It is good practice when Joint Commission is on site to have a team back in the office whose sole purpose is to respond for any immediate questions. And it's also important to note that surveyors may ask others about medical equipment, which include not just your biomed staff, but also clinical staff, nurses on the floor, charge nurses, physicians. So it's really important that you're bridging that gap and that they know what to do when medical equipment issues arises, if a PM sticker is outdated, and what happens when medical equipment fails and the patient is involved. So on the final day of the Joint Commission survey, there's going to be an exit briefing. In my experience, it's been done over Teams, so everybody in the healthcare facility can participate. But it's really, the purpose is to review any findings or requirements for improvement or RFIs. And as biomed or director, whoever's responsible for your Joint Commission should be present for this review. The Joint Commission has also developed a survey analysis for evaluating risk, or SAFER matrix, which you can see in the top right. And it's a way to present the findings and provide healthcare organizations a way to prioritize their resources and focus on corrective action plans in the areas that need it most. So each requirement for improvement or RFI in the final report is plotted on the SAFER matrix according to the likelihood that it can cause harm, so low, moderate, or high, and the scope to which it was observed. So limited, pattern, widespread, with the bottom left corner being the lowest risk and the top right being the highest risk. And the high risk RFIs could be highlighted by the Joint Commission for review on subsequent surveys. So if you've been through the Joint Commission process before and maybe you found an RFI that's on kind of more to the top right of this graph, don't be surprised if they're going to look at that area at the next survey. All RFIs do need to be addressed by the hospital in a 60-day evidence standards compliance report, or ESC, which states what the organization will be doing to move forward to address the findings to ensure continued compliance. And the report will indicate the issues, indicate that it has been corrected, and demonstrate how the hospital is going to maintain this correction. Finally, you notice at the very top, there is a box that says immediate threat to health or safety. You don't want to be here. If a finding is identified in this category, the surveyors will immediately halt the survey. We're going to save questions for the MC. Thank you. And they're going to halt the survey to address that finding. So they're going to issue a preliminary denial of accreditation based on that finding, and the hospital will need to remediate or eliminate that threat within 72 hours or outline a plan to continually eliminate in the next 93 calendar days. So that was a quick summary of the Joint Commission survey process, what to expect. I know some of you have gone through it, some of you haven't, but hopefully that kind of fills in some gaps. But it's important to realize that the survey can differ between organizations, and specifically between deemed status and non-deemed status facilities. So a deemed status organization are dependent on services like CMS or Medicare, Medicaid service of reimbursement. And to receive that federal funding, they must be surveyed by an accrediting organization, which Joint Commission is one of, but not the only. And most of the healthcare organizations in the US do fall under this deemed status. Conversely, non-deemed organizations are not dependent on CMS reimbursement, and so it's probably not a surprise that many federal agencies fall into this category, and that includes entities like the Department of Defense, the VA, like our hospitals, and the Indian Health Services as well. So these non-deemed organizations have slight differences in their surveys. The standards language is a bit different, and the post-survey rules, and they follow different editions of the NFPA 99 code. For instance, the Joint Commission standards reference the 2012 edition, the VA follows the most recent edition, the Navy follows the 2012 edition, and the Army follows the 2018. So there's a lot of variety and range, so just make sure that you know what you're following and those organizational differences. So now we're going to go into the bulk of our presentation on how to prepare. Our site is about to have Joint Commission at any moment, so we're been doing this on a day-to-day. So how can you prepare? First, some general prep advice. Each of your healthcare organizations should have a quality management or similar department whose goal is to ensure continued compliance in the healthcare system. And this group will typically hold mock Joint Commission surveys, which is usually done through an external consulting group, and coordinate tracer rounds to ensure and prepare the hospital staff for the Joint Commission survey. Some things that you can do in HTM or Biomed would be to participate in your environment of care rounds or EOC rounds at your hospital, which is a method of continuous readiness and a good way to check the medical equipment on the clinical floors and prepare for the survey. And similar to EOC rounds, your department can also perform pre-survey sweeps for medical equipment to ensure that PMs are up to date, that the PM stickers are correct, equipment that is medical has an asset number, that they're receiving incoming inspections, and if they are service provided by the vendor, that is documented. I know specifically in our operating room in ICU, we do sweeps every morning by our BMETs. You also might want to consider sending staff to areas that don't typically service the equipment in that area, just for a fresh set of eyes on that equipment. It's very easy to have blinders on. And you can also use this time to prep the clinical staff to make sure they understand your program. I think this one's really important. A lot of, if your hospitals like ours, the nurses are on different rotations, and maybe your overnight nurses are, you know, not the same as your day nurses. So making sure that they understand the process and that you're having those conversations with the nursing leadership is really important. You should also understand that the standards and EPs that are applicable to medical equipment and be knowledgeable of the Joint Commission Sentinel event alerts and national patient safety goals, which are both linked on this PowerPoint. And finally, make sure you get organized and have complete documentation ahead of the survey. So one way to stay organized and to have all documentation in one place is to create a Joint Commission binder. So I took the liberty of using ours from our last survey, right here. It's a bit outdated, but you get the general gist if you'd like to pass it around. And we've included some recommended documents to keep in this binder. So just a note, quality management will most likely be requesting this information from you as well for redundancy. But first and foremost, your medical equipment management plan. We term it the MEMP. It's basically just your basis and outline of your entire biomedical engineering program. And then we've also found it helpful to list out the ECUs that apply to biomedical engineering. These may exceed just 241 and 243. There may be others where biomed's involved, and handwriting out the EPs that are specific to medical equipment, and then providing examples in the concurrent pages, which you'll see when it continues to pass it around. This includes any hospital policies or department level SOPs. Also good to have an inventory of high-risk and non-high-risk counts of equipment in each category and a standardized list of high-risk equipment. So the VA has a service bulletin that defines what is considered high-risk. Or if you use external organizations like ECRI, having that list available as well. And you should also have the PM completion rate for the past 3 years, as well as your EOC reports. Some people do it, the PM completion rate since your last survey. I think it's best practice to do it the last 3 years, whatever you feel comfortable with. And finally, include examples of safety recalls or patient safety incidents that involve medical equipment to demonstrate that you do have a policy to follow. And although this may seem intuitive, please only include documentation that does shed good light on your department. You do not want to raise any unnecessary scrutiny if you include something that is not accurate, or just, yeah, don't do that. So during the survey, you're going to be interacting with a surveyor, and I'm sure everybody, well, raise a hand, who has had a difficult surveyor? Okay, good to know, good to know. All right, so we want to treat it like a job interview and present yourself and, you know, professionally. And maybe they won't think the same way, but you should really act like the same manner when interviewing for a job. So in that situation, you do need to be honest. If you try to lie, they're probably going to catch you. They do this for a living, so they might know the EC standards better than you, as well as other standards. Be helpful, don't be distracted, and just try to be as polite as possible. Since I'm sure a difficult surveyor experience may impact your survey experience. I know at this point, we're really hoping that the surveyor doesn't ask you any questions, but realistically, you're going to have to. They're not going to just magically go over HTM or Biomed. They're just not. So be ready. And the first things first is you want to be as prepared as possible. So make sure you're familiar with the program and you can speak to it. And when you're asked questions during the survey, I think this is a really important point. Only answer the question that is posed to you. And only provide the documents that are requested. I know it's very easy for us to want to show our knowledge and answer something and then bring something else in. but letting them lead the question is really important because you want to avoid any unnecessary scrutiny if you say something that was not directly asked by the surveyor. Now, that doesn't mean that you're lying or holding back information. It's just letting them lead the questioning and the survey process. When you do answer questions, you need to have confidence in your response. This is also really important. If you come off unsure, it's not a good look. So if you don't know the answer or have the confidence, you can ask to get back to them, and that's okay. Don't do it for every single question though, because then they're going to be like, what the heck is going on here? But they will give you some time to provide responses. So in that in between, just call your HTM community, call Bhaskar, call the VA San Diego or your national team or whomever that you're involved with, everybody here that you're meeting today, and kind of getting more information to make sure that you're coming back with the best response. But however you gather your response, make sure that you're meeting, responding to the surveyors in a reasonable amount of time. So back to our last point, some surveyors are difficult and you may get a difficult inspector or one with just, a fun personality. And they may seem to be on a mission to always find room for improvement everywhere. And if you do get this type of inspector, what I would recommend is most important is to try not to get emotional or defensive and just kind of fight with facts. So maintain your cool, and really if you just stick to the facts and you're incredibly prepared, the facts are going to speak for themselves, and that's really the best way to deal with a difficult inspector. So now we're going to get into some very specific standards. So there's going to be a lot of redundancies. Some of the standards kind of cross over, and there's a lot of redundancies if you're familiar with them. But the first standard you need to know is EC 020401. The hospital manages medical equipment risks. And I've summarized the EPs over this and the concurrent slide. So please note that we did recognize the differences between deemed and non-deemed organizations. These are also reflected in this slide. So the bolded and asterisk EPs designate the ones that are specific to deemed hospitals. So ones that depend on center Medicaid and Medicare services for reimbursement. The language, if bolded, also identifies that difference between deemed and non-deemed. These are not pulled directly off of the Joint Commission standards. They are consolidated and concise, just for the sake of time and to get everything on here and a more concise review. So under EC 241, you need to have a written inventory of your medical equipment. And if you're deemed, you have to include all, but non-deemed ones can include a subset with a risk-based approach. You do have to identify your high-risk equipment, which must include life support equipment. And you have to identify the maintenance, testing, and inspection activities using manufacturer recommendations or an alternative equipment maintenance strategy, and they must have a 100% completion rate. And deemed hospitals only must follow manufacturer recommendations for different specific groups of medical equipment, which include lasers and imaging equipment, as well as some others. The next two are only for deemed hospitals, and those include having an inventory of AEM medical equipment, as well as having a qualified person to using written criteria, which is listed below, to support the use of an AEM. And additionally, you need to have written procedures for when medical equipment fails, and you need to identify quality control and maintenance activities to maintain the image quality of CT, PET, MR, and NUC-Med modalities. Finally, you need to follow the Safe Medical Devices Act of 1990 and monitor and report all incidents where medical equipment is suspected in or attributed to the death, serious illness, or injury of a patient. So for EPs under this EC 241, we've provided some recommended documentation to have ready, which you'll probably see in that binder that's floating around somewhere. I've got it there. And this documentation really includes the policies and procedures that cover the following topics: your medical equipment inventory, or subset if your hospital's is non-deemed, and make sure your inventory identifies the high-risk equipment. Your PM procedures documented showing that they align with the manufacturer, as applicable for non-deemed, and following those specific categories identified in EP5 for deemed, and your AEM strategies documented as applicable along with criteria to support the AEMs, program and an inventory of the medical equipment that's specifically on an AM program. Your policy on equipment failures, your quality control procedures for CT, PET, MR, and nuke med, your policy addressing the Safe Medical Devices Act, and your processes for what to do when medical equipment fails. And lastly, additional documentation that you'll need if you are deemed are the qualifications of the HTM staff or BMETs, as well as Biomed that are working on the equipment, as well as the engineers that are choosing the strategy and the criteria for the AEM program. So the next standard, 020403, the hospital inspects, tests, and maintains medical equipment. There's going to be 5 slides for this one. It's a bit longer of a standard when it comes to the elements of performance. So under the standard, you need to perform an inspection prior to initial use. This includes your incoming inspections. If you are a deemed hospital, this needs to be documented, and inspections must be performed after any major repairs or upgrades. Just to note, the VA, we're non-deemed, but in a practice, we follow all the deemed rules. So we apply the same stuff. So it's kind of up to your discretion. You also need to inspect, test, and maintain both high-risk and non-high-risk equipment to 100% completion, and perform testing and maintenance of sterilizers and equipment maintenance on hemodialysis units, as well as chemical and biological testing of the water for hemodialysis. And as we brought up, but I don't think anybody knew the answer, this specific EP under this standard, which the non-high risk 100% completion rate, I know is really hard to meet, as it's almost nearly impossible unless you create a very specified AEM program. Our site does not have an AEM program. We can talk about that in the Q&A later. But this is the most commonly cited standard for the Joint Commission. And so specifically also to SPS sterilizers. So please, as you prepare, ensure you're taking a look at your non-high risk medical equipment PM rates, and make sure that the vendor, if they are providing service on your equipment, that you're gathering those service reports ahead of time. Our site has really found it helpful to complete quarterly audit reports for both imaging and SPS equipment, since we are dependent on those vendor service reports to kind of just have that documentation available when we're in the Joint Commission. So we found that to be very helpful. Scrambling at the last minute, trying to reach out to a vendor and depending on them to not get a citation is not a good feeling. All right, continuing on, you're going to need to ensure that equipment listed for use in oxygen-rich environments are labeled appropriately, and if you are a hyperbaric facility, you must comply with NFPA 99-2012, Chapter 14, and deemed hospitals must have qualified staff inspect, test, calibrate nuke med equipment annually, documenting the results and completion dates. You must maintain the quality of CT, PET, MR, and nuke med images, and the next several are all about medical physicist tasks for certain imaging equipment and modalities, so it might seem a bit redundant, but they do apply over each modality. So a diagnostic medical physicist must test the radiation dose produced by the CT at least annually. And there are specifics in the standard on how that test should be conducted. Also, a diagnostic medical physicist must conduct a performance evaluation at least annually, following specified metrics, and document the results and recommendations for correcting any problems. And this needs to be done for CT and MR, are specific for this slide, but it also needs to be done for nuke med and PET as well. So each lists different specifics for the evaluation though, so please refer back to the full standards for each modality. And additionally, for CT, PET, nuke med, and MR, the annual performance evaluation conducted by the medical physicist must also include testing of the image acquisition display monitors for the parameters that are listed. All right, marathon up here. All right, on this last slide, we're almost there, I promise. We'll get into the good stuff. On this slide for EC243, it shows that you should perform maintenance and testing on anesthesia units. This is really important to separate out after any adjustment, modification, repair, and that before returning the anesthesia units to service, each connection is checked to verify proper gas flow and oxygen concentration. You also need to meet NFP 99-2012, Chapter 10 for electrical equipment in the patient care vicinity. And if you are deemed, you need to meet applicable provisions for the Healthcare Facilities Code, TIA 12.5, which relates to multiple outlet connections for our fun best friends, RPTs, relocatable power taps. We're going to get into RPTs a bit later. And finally, for fluoroscopy or fluoro equipment, also annually, a diagnostic medical physicist must conduct a performance evaluation following the specified metrics and documenting the results for correcting any issues. All right. So again, we provided some similar documentation. It may sound redundant because the standards are pretty clear cut, but what we recommend you have is maybe an example of an acceptance testing or incoming inspection. You'll probably see one of ours referenced in the binder. And this includes, as well as having policies and procedures that cover your incoming inspection, loan or lease medical equipment. Where does the responsibility lie in your healthcare system? Is it on HTM? Is it not? If you do you have a maintenance record of it? The PM process and how you assess for PMs, your method of the PM, is it manufacturer recommendations, is it on an AEM, the timeframes to complete or what is deemed as a complete preventative maintenance, as well as statuses of how many were completed and passed versus corrected, deferred, and for equipment that did not actually receive a PM, like could not locate or in use clinically, what is your policy to follow up with that equipment and making sure that that PM does get completed. Also include policy on dialysis water testing. This may come from the dialysis department, for us it does, as well as the policy on labeling equipment for use in oxygen-rich atmospheres, which same for us comes from supply chain or logistics, and policy on hyperbaric equipment maintenance if you have it. If you do not have hyperbaric facilities, I'd be interested in somebody that does. And in addition to the policies, you should also have the following documentation: a way to identify your IPTs in the patient care vicinity. We're going to go into the specifics on that. And then for deemed hospitals, as we stated earlier, you should have the qualifications, which includes the certificates of the HTM staff or BMATs that are actually maintaining the equipment on your AEM. Acceptance testing, like incoming inspections, like when you first get equipment into the healthcare facilities that you're, looking at it and inspecting it before clinical use. Okay. All right, so where's gonna go this one? All right, some documentation. How to sample incoming inspection work order prior to initial use. If you're a deemed hospital, have samples of acceptance testing. So this also includes major upgrades or repairs, that you have that acceptance testing as well. And make sure any work orders you provided have the appropriate information. So if you're gonna specifically do a Joint Commission binder and you're gonna use a work order, make sure you're using a good one that actually lists the date, the measurements, the values, any test equipment that's used or whatever's called out in that specific PM if it is completed in-house. And for high risk and non-high risk equipment and AEM, PM work order counts, % complete each month. If this has been a pain point for your facility or department in the past, having a narrative, if you don't mean 100%, why? It's really important because like I think I was sharing glances with everybody earlier, getting the non-high risk completion rate to 100% as to why. And finally, for dialysis water, have maintenance records and water testing results and any action items for when colony counts are out of range and how you remediated this, which probably will come from your dialysis department unless you need to. And the last piece of information or documentation for the standard is the imaging, which you should have from the last Joint Commission inspection or the last 3 years. This includes the quality control activities for maintaining the quality of CT, MR, nuclear, and PET, as well as records of maintenance repairs or calibrations performed, as well as having those annual diagnostic medical physicist reports that we spoke to earlier. And especially for CT, they need to test the radiation dose. And it's very likely that this documentation may come from a different department. Maybe your radiology leads have it, or radiation safety. That's where our medical physicist is under. But if that's the case, there's no need to double document. Just make sure you know who's not gatekeeper, this is the wrong word, the keeper of it. Make sure they're not out of office if Joint Commission were to show up. So we just like to be redundant. Okay, a bit more about AEMs. So you've heard me reference AEM, or an alternative equipment maintenance program. And really what this means is that it's a program or maintenance strategy that deviates from the manufacturer's recommendations for devices in that program. So that could be in the frequency of the PM schedule. That could also be in the actual procedures that occur during the maintenance. And the Joint Commission standards that apply specifically to AEMs are listed on the slide. So if you do want to establish an AEM and not follow manufacturer's guidelines, there's certain criteria that you should follow or consider. And first, the AEM must not reduce the safety of the device, and it should be based on accepted standards of practice, like the ANSI-AMI EP 56-2013 Recommended Practice for Medical Equipment Management Program. But you also have to do an inclusion risk assessment for determining what equipment goes in your AEM. You also have to review a thorough maintenance history or history from your own hospital experience, or maybe a third party contractor or nationally recognized sources like AMI. And finally, I think this is the most important note on this slide. For deemed facilities, the AEM cannot include equipment that is excluded from the AEM for the Joint Commission standards that we went over earlier, which includes lasers and a lot of imaging equipment, or any equipment that does not have prior PM history. We're going to have a discussion. Sorry. And in addition to meeting the guidelines for AEM programs, you're also going to need to have documentation for your AEM program, especially for a Joint Commission inspection. So have a list of all the AEM equipment on your inventory, and you'll also need to have qualification records. Like, I think this is the third time I brought it up. I said it was going to be redundant, for the staff that are responsible for developing and managing the AEM programs. So those would be your managers, your engineers, as well as the staff that are actually hands-on maintaining the equipment. These would be your BMETs. You also need to make sure that you're, just like non-high risk and high risk on a PM, that the AEM frequency is at 100% completion. And you need to have your rationale or justification for why you're putting a certain subset of equipment on an AEM. And lastly, you need to perform routine evaluations on your AEM. You know, don't not look at it for 5 or 10 years. Can we say it for the end? You can have both at the same time. Yes, for specific. Yes, you can have a certain equipment on an AEM and then certain, like, imaging equipment. You're not going to put it on AEM. That would violate a Joint Commission standard. But maybe you're choosing to put your infusion pump on an AEM because, you know, you have history that it doesn't reduce patient risk and you haven't had any corrective issues with a specific model. Like, you're going to do that consideration in an AEM management. But we'll have a whole discussion at the end. So for more info, you can look at this link. It's also in our PowerPoint. So I know that's a lot, but as you can see, you need to collaborate with a lot of different departments. It's not just biomed, right? And so these are some of the key services that you need to, you know, develop your relationships with. You might need to lean on them and depend on them when Joint Commission is on site, because they may have the specific documentation that Joint Commission is going to be requesting. So radiology or imaging service, they're most likely going to have the quality control testing for CT, PET, MR, and NUCMED images. Radiation safety, they're probably going to have the physicist reports needed for CT, PET, MR, NUCMED, and fluoro. Supply chain will probably have the policies and procedures for labeling equipment in oxygen-enriched environments. Sterile processing, depending on where your scope falls, they may have the sterilizer maintenance documentation. We cover it, but I know some sites it's different. Hemodialysis would probably have the dialysis water testing. And just overall, all clinical services when it comes to, you know, user maintenance, everyday wipe down procedures, stuff like that, the clinical services should have documentation of conducting user maintenance for the manufacturer. But Biomed is typically responsible for the two main Joint Commission standards that we reviewed, 241 and 243. But there are many Joint Commission EOC standards that we didn't talk about, where maybe Biomed would be leaned on just like we're leaning on these other services for other environmental care, and that includes safety, police, infection control, etc. So I'm going to pass it over to Bhaskar, who's going to continue our discussion on ways to prepare.
Can you all hear me okay? Perfect. So like Lindsay was saying, we have several different EPs, ECs within the environment of your chapter. And the biggest takeaway, which I just want to mention is as a biomed professionals, taking care of the patient, equipment, taking care equipment. I think we need to kind of make sure that we are kind of meeting the regulatory requirements. So our medical equipment management plan is kind of meeting the requirements that we have from the Commission, any other regulatory agency. It's just not joint commission. So with that, I think what I would like to briefly cover is in terms of some of the common findings. It could be in the last year, it could be in the last 3 years that we are kind of noticing within the environment of care chapter specific to biomed department. So some of the common themes, like we are saying, like Lindsay was saying, the biggest core is to go back to your inventory. Right? It all kind of goes back to your inventory, what you have in your system, and how are they being tracked, and how are they being kind of categorized. They're being depending upon different risk levels. So the biggest one, which we are kind of noticing in the last few years, is how are you kind of managing your medical equipment risks? Do you have an accurate inventory? How are you categorizing the various risk categories within your medical equipment section? So it is more about making sure you do have an accurate inventory and have a way to kind of constantly monitor the accuracy of it. So I don't know if anyone is kind of doing like a sampling, kind of randomly looking at some of the work orders and see what kind of documentation we have. At the same time, having a group like Lindsay was saying, to go to a different area where they don't typically go into and kind of look for equipment. So these are the things that can help you make sure that you do have a most accurate and up-to-date inventory on track, and make sure you have tracking them in the system. And at the same time, when it comes to the inventory, one of the other biggest factors, how you are categorizing the risks, what kind of a documentation you have. So those are the things that you need to really kind of dictate or kind of make sure the team is kind of on board with the practices you are following. And one of the biggest one, which is more kind of an acceptance testing or incoming inspection. Whenever there is a new equipment that is bringing on board to your facility, make sure you have a documentation referring to like an incoming inspection. So those are some of the common findings, specifically going back to your the core, which is the medical equipment inventory. Another issue, more kind of a common finding that we are noticing is maintenance frequencies. So you can go back to your inventory, look at your high-risk equipment to begin with, identify the type of risk frequencies that we have in place, make sure are they kind of in correlation with what the manufacturer recommendations are. But if you do have an AEM program, make sure you are documenting the frequency that you are kind of proposing as part of the AEM strategy. At the same time, having an ongoing evaluation of the program. So if it is something that you are deviating from manufacturer, you are kind of going back to that particular device type or a group of inventory assets, kind of making sure are you still kind of meeting the requirements? Are it still be okay to continue to maintain this piece of equipment based on the behavior, like in terms of the failure rates, the last PM done, and how it is being maintained, and see if it is still kind of makes sense to maintain that equipment on an AEM program. So that is one of the things that we are kind of noticing in terms of not identifying the frequencies, especially some of the lab equipment. That's a gray area. Depending upon your role at your hospital, kind of check with the laboratory director or the department and see how they are maintaining the hoods or the biological cabinets. And if you have a contact with the vendor, make sure there is a way that you can obtain the documentation, especially when you are in a joint commission service going through that. So that is something that we are kind of noticing. At the same time, always reference to your IFUs or the AEM strategies and make sure you have a thorough supporting documentation that justifies your maintenance schedules. Moving on, and the other one, which again goes back to uh, the core, which is the functional checks. the safety and the functional checks before using any kind of device, high risk, non-high risk, and especially many hospitals kind of miss the documenting this inspection before patient use. So you can have a way that you can set up in your CMS system. As soon as a new piece of device is kind of created in the system, you can have a incoming inspection work order generated. So that way, you have someone has to acknowledge the work order, make sure the proper asset tag, control number, or the PM, all the things are kind of categorized. If there is an acceptance testing or the vendor report as part of the new equipment, it's all kind of tied into that incoming inspection work order, and you are closing it. So there is some of the things that is very critical as a biomed or a HTM professional that we have that in place. So you can have some kind of mechanism within your senior system. So like I said, whenever you create any work order or you're decommissioning an existing work order, you can kind of generate those ad hoc work orders against the assigned service technician. Go ahead. Yes. So you can obtain the operating, what do you call, the incoming inspection report from the manufacturer who came in to install the device. So you could also keep that and say, hey, on the day one, this is the functional status. Yes. Yes. Any other questions on this? Moving on to the next one, which is more on your sterilizers. This is something, depending upon the type of service model that you have in place. If it is something that is kind of maintained by in-house, make sure you have a documentation which kind of, complies with the manufacturer recommendations, all the kind of safety checks as per the manufacturer requirements, or kind of complying with those requirements, which is really critical that we have noticed in the last few years, especially on sterilizers. So few things that we have done at some of the locations is kind of a sampling. You can go back and look at your service history on a quarterly basis and randomly kind of put some of the high-risk equipment, sterilizers, and see the type of documentation we have in place and who is doing that work order. So if you have someone doing in-house, make sure they are complying with the manufacturer requirements, checklist, whatever the parameters they have in the manufacturer recommendation. If it is under a contract with a service provider, make sure the documentation is intact within the system. So those are the things that highly kind of recommended on sterilizers. The next one, which Lindsay, go ahead. Yes, yes. And again, like I said, if you are following an AEM recommended procedure or a strategy, make sure you have all the supporting evidence. It could be the history within your hospital or some other, other hospital that you have in place, and how they are being maintained, and at the same time, ongoing evaluation that it still meets those AEM requirements and kind of continue to be in the same way. So make sure you have those. The other one, which Lindsay briefly touched upon, is check with your dialysis department. Again, most of the times, Biomed doesn't really get into the supporting the service component of dialysis, but talk to the departments and make sure like who is maintaining your dialysis equipment and where is the required documentation. Is there a way that we can obtain that, especially if you are going to a joint commission circuit? So that is something very critical. At the same time, the documentation should also kind of cover about the water quality test. That has been something that we have been noticing in the past few years. Not only the regular maintenance, but they are also looking for the water quality test to be being maintained and done by the service provider. The other one, which is more on the test equipment. Again, the entire team that we kind of manage or day in, day out patient care equipment, they use some kind of a test equipment and perform repair or perform maintenance. To make sure that test equipment is also being calibrated on time and as per the schedule. And at the same time, a good practice, which is something like there is a way that we can document the test equipment that we have used against your work product. It's a kind of a good management practice so that we can trace back and see if there is any test equipment that failed during calibration. We can go back and see where it was used in the past. So that is something, that you should kind of go and look for your test equipment tickets and see if it is being properly documented. This is something recently in the last year, I know the Joint Commission has revised the EP, and I know Arif is going to go into the details, but I think that going back to the core, this is one of the most commonly cited findings within the infection control. So there is pretty much the lack of training material, how the test strips are kind of ignored, and at the same time, it has to be some kind of an SOP in place, and then evidence of training is happening when it comes to your infection control equipment, despite all the other areas. So that is something that we may have to go back and see with the infection control departments, make sure we have all the documentation support. Other regulations. So beyond, Joint Commission, there are several other regulations that we see, which is one of them is Biomedical. Maybe some of your hospitals might be under their accreditation agency, but they are also kind of picking up, and they are more on an ISO-based driven methodology, quality management system. And at the same time, one of the other critical area, which we always kind of refer to as NFPA 99. So most of your facilities standards kind of refer to that, but within the Biomed also, we also talk about the NFPA 99, which talks about your RPPs, how you are managing the code strips, what are the expectations, who can support them, who should be mounting them, where should be mounting them, and all that, it kind of goes back to your NFPA 99.
Thank you, Bhaskar. Everybody can hear me at the back? Okay. Good morning, everyone, and welcome to the session. Thank you to Bhaskar and Lindsay, and also Catherine, who's not here, to kind of talk about these standards. Sorry, we're running a little bit late, a big topic to cover. So let me try to hit a couple of other areas. There are other Joint Commission standards in the Environment of Care chapter. I mean, those are listed here. I don't have to go through all the details. These slides and recording, by the way, will be available to you. This in the new version is EP3, which is requirement for having the library of manuals, procedures, etc. The other one is about the plan, which Lindsay was talking about earlier, and obviously the one in terms of recall. This is the one that Bhaskar was talking about, that's changing the infection control chapter. And talk is the same. We need to have a process, procedure for cleaning, disinfecting, sterilizing medical equipment. And the standard now is IC 040101. You can look through the details. This again is, as Lindsay and Bhaskar mentioned earlier, it's not all details. You need to actually look at the chapter itself. This is a good document that I was able to pull up. So you can look it up. Talks about disinfection and sterilization in healthcare. The other often forgotten standard is the human resource standards. Obviously, this is not just for Biomed, but for everybody. And it kind of talks about the different things. Obviously, there's specific things for nurses and other clinical professionals as well. And you need to make sure you comply with that. Includes the competency of staff, evaluating their performance, making sure they're going through the orientation. So the documents you need for the survey preparation, that's the important thing, is need to have the position description, whether they've gone through the hospital orientation, department orientation, okay, performance evaluation, competency assessment, and training records. So the people who work for you are competent, and you have made that verification. Another chapter is the IM standard, which is the information management standard, a bunch of requirements related to privacy and cybersecurity of data, and all those are mentioned here. And you can look through the details actually in all these standards in the IM chapter. All right, leadership. So this chapter applies not just to the leadership of Biomed, but all leaders in the healthcare organization. And I have just picked up a few, and these are just snippets, where you're required to obviously comply with law and regulation, you're required to, maintain a culture of safety, quality, and make sure, you're making improvement of performance. This is about grace periods. I think everybody knows about it. The details are there. It's too detailed, but that's how Joint Commission has defined it. You guys can look through it. If you have questions, we can talk about that. And, okay, the other thing is the National Patient Safety Goals, which Lindsay was talking about. Nothing has changed for 2025. You can go to the Joint Commission website. It's still the alarms for medical equipment, which have been around since I've been around. So in this business, so please make sure you have a policy that addresses that. It's a challenge for many organizations where alarm fatigue is an issue, and these are some of the details of the specific element of performance. Where you're required to have a policy, you need to establish their priority, you need to kind of talk about different things, their input from the staff, risk, etc. And this is something that Biomed can't only write, but they have to work with their clinical counterparts. All right. So the other thing I want to talk about in the next few minutes that are left, sorry, we're running a little bit late here, in terms of what resources are out there. So the primary source, and we can go look Google. Google is a good source, but I always refer people to the Joint Commission website. If you have any questions specific to Joint Commission, there's an online form that is available. You can request. The only caveat with this form, I just want to mention to you, depends on your organization. Don't go out filling these forms and submitting it. Usually there's a quality management department, performance improvement department in the hospital. Your director or manager of that department, ask him if you can submit this form, because they may have an answer to those questions. So just, you're not running your own department where you're part of the hospital. So just need to make sure that's going through that. The other important thing to look for is the Joint Commission survey FAQs. That's an official website. You can go to this link here. They have different FAQs regards to different standards. People have a lot of questions, and these are official interpretation from Joint Commission. These are some of the examples that they gave about this. All right, and then these are about, here, power receptacles, inventory risk assessment, etc. And as I said, if you need to ask a question, you can go through their standard interpretation. So Amy has a bunch of articles published, and they bring in the Joint Commission surveyor, the person who leads the program, and they have some videos available. The other thing people often forget is the environment of care news. This is an official publication that not just only provides you detailed information about environment of care, emergency management, life safety standards, but allows the biomeds to look for questions about that. And these are written by people who are part of the Department of Engineering of Transformation. This is an example of that newsletter. It's by subscription, so usually your hospital may have a subscription you can look at. I'm part of ACC, so I just wanted to mention to you, if you remember, you can go to this link, and we actually invited one of the Joint Commission surveyor, the lead of the Joint Commission, and his webinar is available. He just presented something as early as last year, so you can go through and look at it too, and there are other webinars too as well. Okay, this is an important thing, as I mentioned, quality management or compliance department, different names in different hospitals. Make sure you know who the people are, because these are the people who are not responsible just for the biomed, but for the whole environment, whole Joint Commission standards and other requirements. So just coordinate with them, work with them on monitoring, updating your policies and procedures, because they will be acting as your liaison with the Joint Commission survey when they come up. And they can also help you answer any questions that you may have, because that's what they do as part of their job at the hospital. The other thing that I think was mentioned earlier is helping do mock survey. We are having actually a mock survey in our facility right now from our vision. They're helping us prepare for that. And besides the Joint Commission provides mock surveys, there are other private outfits that provide mock surveys as well, so you can use them too. This is another thing that I picked up, and I don't know if it's still valid or not. This is about CMS validation survey. This is for the deemed status hospitals. It states basically that they will be observing these accreditation organization surveys